And we're back, day 2 at Becker's. Chris, thanks for joining us.
Yeah, absolutely. Thanks for having me, Brian.
In the icebreaker column, I was listening to one of your podcasts.
Yeah.
And you have a cool story to tell, I think, about a Sprinter van. And when you were on that podcast, I think your host had said, well, let's see where that goes.
Okay. So we need an update. Okay.
Yeah, that was a pretty innovative idea, I thought. So what happened with the Sprinter van?
Well, COVID happened, and the Bay Area, you've got to make do with what you've got. So we live in a tiny house. It's about 900 square feet.
Yep.
And my wife was working from home. I was working from home, and we have a 5-year-old and a dog. So I don't know about in your house, but for whatever reason in remote work, we all talk louder.
Oh yeah.
So we were.
That's why I got booted out.
Trying to override each other. So I was sequestered to the shed in the backyard, where we would get the morning calls, the emergency calls for what the next day's plan was for COVID, and the team would sprint and then try to deliver something the next day.
Yeah.
And so I'd actually had the desire to do this for a while. Luckily got in before the whole market erupted on these things, and built it from scratch. I think you'll appreciate this though. As innovators, you live in the data world.
Yeah.
We live in the digital world.
Yeah.
And both those things are amazing in their power, but they're also not as tangible. So doing the build out was almost like a cathartic decompression from the intensity of what we were doing
dealing with
digitally. So to literally see progress day by day, teach yourself electrical, teach yourself plumbing. Yeah. And so now it's an office. I work out of it. You can reserve it like a room. If I get bored of being on our little house campus, I'll just drive down the street, work from there. And the one goal, though, the vision for it, which has not happened, and I still want to do this, is we have a lot of rural locations, and we go up to like the North Coast, where it's hard to get to some of these places, and just by default, a lot of the leaders don't visit those sites very often. So my hope is to go around and tour some of our sites and really listen to the patients and the nurses and our staff and what's going on for them. I did do it virtually with managers, and turns out it was just more efficient to do it in Zoom, which was disappointing because I wanted to get out there.
Okay.
But we'll get out there, and I still want the sort of like, the executive sleeping in the parking lot.
I love the idea,
really
though.
Just being like a normal human,
I just thought the idea was cool, because in a normal situation, you probably get out to all your facilities and you want to break bread with your team and understand. But what a great way to do it, right?
Yeah.
Mobile office.
So here's another, not that all things, we'll move on to a bunch of topics, but one thing happened, which was someone came to help me. A guy was with his family. He doesn't have a home. He just remotely travels to different jobs, and he helped me in the electrical.
Okay.
So I said to him, do you mind if I watch you do what you're doing? He said, no problem.
Yeah.
I get to talking to him. I said, what were you doing before this? He said, I was a Tesla mechanic.
Okay.
And he goes, here's how the job changed over the years. Before, we had a Tesla service site. The cars would come to us. By the time I was done, I was remote monitoring Teslas.
Oh, wow.
I could see what the project was from afar, identify the part, drop ship the part to a lesser trained mechanic who would go to the person's home and install the part. And I thought, you might have just described the future of healthcare.
Yeah, no kidding, right?
Of this sort of proactive data management layer in telling, the next move of any particular ecosystem. And not that it was the end-all, be-all, but it's really inspiring to think about what other industries are doing that we can cross-fertilize back in to
absolutely.
healthcare.
Well, especially to your point about digital, gathering and centralizing, digitizing the data. Yeah. And then making the data through signals and IoT devices, things like that. Right. Making the data pulse. Yes. It's the opportunities are endless, right? Yeah. Yeah. So that's probably a good segue to how does a guy like yourself inside of Sutter, how do you prioritize when it seems like on any given day you could shoot an arrow 360 degrees and hit valuable things, but how do you hit the most valuable and sort of use innovation to pay for the next wave of innovation? I guess what's your innovation process?
Process is different than priority, so I'll take both.
Sure. Yeah.
So priority would be all of healthcare needs touching.
Yep.
And the idea is like you just have to get started. So the perpetual question I love on the team is like, all right, what are we doing Monday?
Yeah.
To get us from wouldn't it be amazing if to how do we practically make something like that happen now?
Sure.
And honestly, I think this is healthcare's heavy weight and where you can get caught is since it all needs to be done and it's also meaningful, like why would end-of-life care be more or less of a priority than oncology? It shouldn't be. All of it needs to be done, which is why I think systems can get stuck on which one should we do first and second. So to address that, we think about platform build. So if we build something for a service line and then make it a little bit more self-service for the service line, they can author the experiences on that.
Sure.
But we've created the playbook to do that in a repeatable way.
Yeah. Or
in the world of data, we started by collecting data feeds from the world off of Aura sleep trackers and continuous glucose monitors.
Yeah.
But to us, it didn't matter what the signal, what the device was that was spitting off information. It was, we just want to be able to build the infrastructure to start doing that.
Yeah.
And then over time, whatever the devices are, we'll start to roll them on. So if that's heart monitoring or remote hospital, all that, we just need to make sure there's a mechanism to do it.
Yep.
So that's that. And in terms of process, the other one I would say though, which is has influenced the team, is philanthropy. So we have people that have had good and bad experiences in healthcare who, just given our location and where we are, they want to see change. So we developed a youth and adolescent mental health digital support tool during before and during COVID that we did because two mothers came to us. They said, our children tried to commit suicide. That's how we met each other. The experience was horrific, and this needs a complete rethink. So what we did then process-wise is we worked with youth and adolescents. So many times coming from IDEO, this is just like innate. This is how you do things.
Right.
But it's amazing to me in healthcare is like we look at the problem from afar and then we try to, do the solutioning from afar.
Right.
We did so many co-creation sessions with these youth and adolescents. It's their product.
Yeah.
All we did was kind of
that's how it should
translate.
Be, right?
Yeah.
The users need to be the drivers.
Yeah. So that's now all done through text because what the youth said is, I don't want to go to somebody's office.
Yep.
There's stigma around these conditions.
Yep.
I don't even want to talk about it, really.
Yep.
And I want the help when I want the help, which might be at 2 o'clock in the morning.
Yeah.
So it's all text-based. It's called Scout. And by the end of this year, we'll have 70,000 youth in that platform. And that just feels good. And then you look at the friction layers, take out the friction layers.
I'm getting goosebumps,
Yeah, and it's not the end-all be-all for healthcare. It's a resiliency tool.
Yep.
But we see that PHQ-9 and GAD-7 scores come down, which is what you want on anxiety and depression. And the other insight was these youth have parents that are very concerned and worried. So it goes into two tracks. And the parents have 12 weeks. And they're getting their text messages. Here's how you can be supportive, and then that's different content than the youth and adolescents are. So, really fun project, really hard project, really meaningful project. But as you can hear, it is really hard to prioritize because mental health needs it. Like right away, it's like, well, why is that only for youth? Why isn't that for everybody?
Yeah.
So you've got to focus in and just get something done, and then move on to the next one.
And it seems like in that, different cohorts, we actually have done some stuff in chronic disease and diabetes, and you do learn a lot in focus groups, like really detailed focus groups. Not all type 2 diabetics see their condition the same.
Right.
They see themselves in groups, and they can only relate to certain groups.
That's right.
You could have a rancher that works every day and he's a type 2, which is different than a 14-year-old.
That's right.
Right, that is dealing with just doesn't think she can relate to the rancher's disease in the same way as somebody her age.
Yeah.
Right?
It's unfortunate that we do this, but we label healthcare.
Yeah.
We'll label people by their condition. It's like that rancher doesn't say I'm a type 2 diabetics. I'm a rancher.
Yeah, exactly.
I'm a dad.
That's right.
I'm a hardworking person who happens to have a condition that's a hassle.
Yeah.
So, yeah, I agree with you wholeheartedly. And this is the world of digital and data is really powerful for that. Like meeting, I met a 28-year-old who had a really rare cancer for someone her age, and the support groups were things like, impacts of a hysterectomy. But if everyone in that room was 60 and she's 28, there's just no relatability layer.
Yeah.
So now, she can be matchmaked to someone in Europe who's also 30 or 20 and has the same condition, and now they can connect. So it's a really interesting world we live in now.
Yeah.
Good and bad.
So we have, depending on what report you read, there's $1 trillion of waste.
Yeah.
Half of that is administrative waste in the back office. A lot of areas we're focused on with this series. I'm just curious, how do you guys think about that waste and using opportunities to fund, like a lot of folks we talk to want to use the back office and automate as much as you can and shift those dollars more to the patient, right?
Yeah.
We're patient care. We all know that's why many of us are in this.
That's right.
What are you guys doing? How do you think about that?
Yeah.
And what are some things that you guys are doing in that regard?
I think that anywhere you can gain efficiency, you should do it. And U.S. healthcare is crying out for more efficient ways to do things.
Yep.
Your business does this. How do we simply guide people to look left? Your whole team's looking over here, the issue's over here, and the data is telling you that. So there's that. I think the other thing, though, is what's the next order thinking that's going to take us to a different place. So for example would be, right now we really think about digital as enabling today's care more efficiently, but we haven't really ingested the whole idea that digital is actually becoming a component of the care.
Yeah.
It's actually delivering part of the care itself.
Yeah.
Sure. And we have amazing humans that play an intellectual role, a navigating role, a hand-holding role, that need to augment that. But they're in a different relationship now. It used to be that digital's there to smooth how you get to me or how you see me. And now, like we're doing AI reads for lung nodules. Our radiologists are amazing. It will augment what they do. It helps them be more efficient.
Yep.
And because the costs go down so quickly, then why not just do reads where we could never afford to do reads before? So for example, if we've got the imaging, let's go ahead and just process it for a couple other areas of the body that we weren't even considering, but oh, by the way, if somebody's here, the AI can do the read.
Yeah.
And so that's changing the relationship between, and I like you, it's like you can't keep all of this in your head. How can we expect our physicians to do that?
Sure.
So the data is helping everything from matchmaking. Like I look forward to a day that should be here now is much better matchmaking between patient and clinical trials, for example. That's a data and matchmaking move. So this should all create more efficiency. And yeah, I think we've got to streamline what we've got, but also concurrently build a fundamentally different care delivery methodology. And that's what we're here to do. So the tough part is you need to do those things at the same time.
Yeah.
And so there's tension. There's going to be natural tension there.
Sure.
And right now that tension's as high as it could be. We've got COVID burnout. We've got, shortages of staff. We've got really high inflation. Like society's irritated.
Yeah.
to put it
you
lightly.
mentioned COVID. One of my favorite things to talk about is silver linings from COVID.
Yeah, of course.
So, because everybody's had them.
That's right. Thank you for asking that.
Yeah, sure.
For us, I think it's silver linings were in healthcare, being able to see just how fast the thing can move, and how when you saw the unexpected breakthroughs in things like regulatory changes, turns out like that's That was a big deal.
That was a big deal.
And I was taken back myself as like, wow, I didn't realize that was so instrumental in the adoption. Like being able to drop state lines, being able to parity reimburse is like, whoa, it's all set up now, temporarily. Yeah. Hopefully more permanent. Yep. That layer is smooth, and the physicians, everyone's all in. This is the only way we can do it. So that was awe-inspiring, despite, you know, how much energy that was taking. A lot of adrenaline that then wore off.
Oh, yeah, that's right.
And then on the family side, we, you know, during all this, we have a 5-year-old. She was 3 when it started, and being able to take her to school and see her, I just would have missed that. And it's so cool that we get to see her grow, and without compromise to the contribution to the job. Yeah. And that's how it should be. Yeah. That's how it should be.
That's so true. There was some amazing bonding with, you know, family.
Yeah.
You know.
Yeah. And last, I'd say just not taking things for granted. Like, we would have taken this kind of conversation for granted, right? This is
for sure.
Just being able to experience life as like a human again. Yeah. And just recognize, as cool as digital is, it has its limitations, and it turns out a hug feels pretty good.
Yeah,
you know what I mean?
Absolutely.
So things like that.
Human connection.
Yeah.
What else should we be disrupting? I mean, with your background in IDEO too, I always love the IDEO way of asking questions, you know, insightful questions. Uber, and we all know Uber and Airbnb and all of those things wouldn't have been asked if you didn't ask those questions. Like, what if I could click a button and somebody would just show up and drive me somewhere?
Yes.
Right? So
yes.
Have you brought some of your IDEO background to the culture? And because, you know, read 1,000 books on innovation, it's always about probing, insightful, and sometimes difficult questions. Yeah. Right?
Yeah. I think the things that the process has been really helpful to transfer from IDEO in. I think, you know, the implementation challenges are harder in healthcare. It's more regulated. It's, you know, but it all still applies. So it's like a universal truth that you know. And I think what I've observed, and I'm sure you see this too, is the creativity layer it's interesting. It needs like an infusion of creativity in healthcare. I understand it's a serious topic, so it's very natural that sort of gets extrapolated out, and it's very science-minded, which again is critical. But if we apply that to every single thing that we do, we'll stifle some creativity. Yeah. So I think the other thing I learned from the IDEO days is healthcare tends to kind of like take emotion and respond with logic. Yeah. Right? So all this emotion's coming at you, something somebody's navigating, and we'll have very practical advice, or therefore we should get a lab. And you know, and so what IDEO has shown us is like it's actually through the emotion that you create engagement, trust, connectivity.
The heartstrings, man.
Yeah. And it's through that emotion that on the other side of that is a clinical outcome, is a relatable layer. It's like, it's understanding that a cardiologist saying you should exercise more and eat right, realizing that emotionally that's so disconnected from the reality of that person's world. Absolutely. So the IDEO way is like, let's figure out the reality of that person's world. Yeah. And then get into the layers of like, what would it take to change that? So I think, that's been really helpful. And then you mentioned Airbnb. That's a company that really inspires me, Brian and Joe and that team, and seeing the origin stories of how that company was built. And the story that...
They're doing amazing things to support this cause, too. Wow.
Yeah, and teaming up with them in unusual ways. During the COVID, when we were getting the call-outs, we were needing to load balance. We were expecting these centers where tens of thousands of patients would need to be cared for, and we were going to have to shift a lot of people in the system to build those centers. And Airbnb was all in. They said, like, well, we've got owners of houses that want to help. We'll designate them in their related distance from the hospital sites. They've been amazing partners.
Wow.
Also looking at affordable housing and whatnot with them. But here's the question they asked, which I love, is it's a great interview with Brian Chesky on Masters of Scale. This is how Airbnb will ask itself, okay, if we want to create the trip of a lifetime and get an 11-star experience, people go like, how do we get 5 stars? They go, how would we get 11 stars?
Yeah.
And so they'll take someone like you and they'll say, here's Brian, and how would we create the best trip of his life, right? And just go no holds barred. As you come off the plane, people are applauding you, you know, like all this like ridiculous stuff.
The red carpet.
Yeah, like what's the experience that you want? And then they pull that off, and it's expensive and it's not scalable. But what they ask themselves is, what did we just do that is repeatable?
Yep.
And then that becomes the product roadmap for things like Airbnb experiences. That was a great one. It's like, it's more than just the place you stay. It's what you do. And how do we nudge people a little bit out of their comfort zone? They'd studied this. It was like, if you do one thing that was like, you pushed yourself to do it, then you had a much better trip, you know? So healthcare can take that.
And they're selling experiences with that kind of question. You're not selling a place to stay.
No, exactly.
You're selling the experience.
They
right?
get it.
Yeah.
And they get the brand and the whole ethos of belong everywhere and whatnot. But I think for healthcare, it's, now certainly, like clinically you can't do that. You don't want a surgeon going like, hey, how do I do the heart surgery of a lifetime? And I've never tried this before.
Yeah, exactly.
But still, from an experience layer, that's so true.
Yep.
And so that leads you to IDEO-like questions. So the first project we did in the system was reimagining end-of-life care, because it was very expensive. People weren't having a great experience. How do we close this up?
Specifically hospice or?
It started in hospice, but we were looking at the economics and we were looking at just this experience layer, and there was internal clinicians that were up for this because they were seeing things like people aren't filling out their advanced care directives. You know, we don't know what their wishes are. We don't know what they want. And it creates a lot of tension in families, and you put all these big decisions on families, finance and otherwise, all at once, and it's not fair. So with IDEO, we actually sent out a global challenge that said, how do we reimagine this? Started with stories around the world, and that led to, turns out the last sense of your body to go is your sense of hearing. And the sound, we found this woman named Yoko Sen, and she was taking end-of-life sound requests. So that was just really creative and insightful. So still, like, you're not getting anywhere clinical yet. You're like, well, what's this mean? But then let's pull this all the way back to an advanced care directive and a power of attorney and all that.
Sure.
Now a primary care doc can say, here's some things you'd like to fill out, and included in this is just stuff like, what's the last sound you want to hear? Which is a very different question. Like, someone's like, oh, I don't know, what would that be, you know? And it's an emotional question. So is that enough to create interest to fill out an advanced care directive that has a lot of other clinical applicability through emotion? And then the second concept that came out of that I still want to build, so maybe we'll do it together, is this concept called vicarious, which is, especially in COVID, people were dying alone.
Okay.
And no one else could be there.
Yeah.
And a lot of people, like, the end of your life will come and you don't expect it. You don't know when that's happening.
Sure.
And people had things that they'd wish they'd done. So you have this young part of the world that's struggling with anxiety and depression and mental health. That's not reserved to that group, but that's a really bad issue in that age range. And you've got older folks generally you're older when you pass away, not always, but most of the time. And we were starting to matchmake this concept called vicarious, which is end-of-life wishes picked up by youth, and they go and live the experience. We pipe it back to the patient, and it's like, this is what it smells like, it feels like, it looks like, helping the mental health of the youth and the dying wishes of this patient. Wow. It's like, that's where it's at. Like, that's emotion meeting emotion. And there's a bunch of things, like when we went to prototype that, turns out you can't predict exactly when end of life is. So you do the matchmake, and so then it's like, okay, well, that concept gets iterated to, it's a tribute for someone who's passed away, still helping the mental health of younger people, even perfect strangers. So those are the kinds of things that, they sound far-fetched to healthcare when we're talking about revenue cycle and access to care. And the truth is they all need to be done. A major piece of work we're doing is just access to the care.
Yeah.
That's a huge issue. So these things aren't competing with each other.
Yeah.
They all fit on a roadmap around like, here's healthcare the way that
There's
we wish
convergence
it could be.
throughout all of these nodes.
Yeah.
Well, hey, we could talk. I could tell that you and I could talk for ages.
Yeah.
So we'll have to have you back.
Well, tell me, I'm curious how you see data playing a role in everything we were describing before I let me go.
Yeah, it's like the oxygen and the blood or the electricity. You got to trap the data, make it alive.
Yeah.
Make it actionable, which could be a pull or a push.
Yeah.
Right. But it's all about understanding the use cases and what's the tip of the spear and the value equation.
Yeah.
The pipes and the plumbing and the technology is the easy part, even though it's hard. But it's, our mission is like it sounds like a cliche, but the right information to the right user at the right time to really move the needle on something, right? And data is the new oil. We live in a data economy. It's all very slogany, but it's just, but it's the truth.
Yeah.
We do live in a data economy.
Yeah.
And you're right. It's endless that, where you can go with value. So you just have to have a process to start and create value, and there's a return, and then fund the next thing, and then it becomes exponential. But
it
looks like we're going to have to cut off.
Yeah, no problem.
And but we'll have you back, and
let's do it.
We have some follow-up calls. So
sounds good.
I just want to thank you.
Thank you, Brian.
It was a great perspective.
Thanks so much. Yeah,
it's so nice as we're getting all these different perspectives.
I bet. I bet.
Really appreciate meeting you.
Yeah, you too. Take care.